Today we discuss the topic knee biomechanics. Structure of the knee joint. It is a complex diarthrodial joint which is a highly modified hinge joint. It has three compartments: medial tibiofemoral, lateral tibiofemoral, and patellofemoral joint. What is the tibiofemoral joint? It is a dual condylite articulations between the medial and lateral condyles of the tibia and the femur, composing the main hinge joint of the knee. It is considered to be the knee joint. Structure and skeletal of the knee joint. Knee joint is composed with the distal femur and the proximal tibia. The femur and the tibia are the largest long bones in the body, and they perform the principal structural, weight-bearing, and locomotive functions of the lower extremity. Femoral medial condyle is larger than the lateral femoral condyle, and it is less convex and extends further distally. Lateral femoral condyle is smaller and more spherical in shape. The domed intercondylar notch contains the femoral origins of the anterior and posterior cruciate ligament. In proximal tibia, medial condyle is concave and longer, while the lateral condyle is smaller and mildly convex. Bony intercondylar eminence, including the tibial spine which separates the condyle and is distal insertion of the anterior cruciate ligament. The femoral and tibial condyles are covered with a thick hyaline cartilage and articulate with each other. These are the condyles of the femur and the tibia. Patella. Patella is the largest sesamoid bone in the body, which is located in the quadriceps tendon. Articulates with the trochlea of the distal femur, in contrast to the tibiofemoral joint that is in constant opposition through the knee's full flexion and extension arc. Patella engages the trochlea when the knee is flexed more than 30 degrees. Patella enhances knee biomechanics during active extension by increasing the movement arm of the quadriceps. Therefore, it is subjected to magnified contact forces that can reach 8 times greater than the body weight. Reflecting these high contact stresses, patellar articular cartilage is the thickest in the body, about 7 mm in thickness. Stabilizers. The knee joint stabilizers are ligaments, menisci, bursa, muscles, and joint capsule. Ligaments. 4 major ligamentous structures are present in knee joint, which include medial collateral ligament, lateral collateral ligament, anterior cruciate ligament, and posterior cruciate ligament. These ligament structures statically stabilize and dynamically constrain the knee motion. Medial collateral ligament is broad ligament and superficial layer arising from the medial epicondyle and fanning out over the medial side of the tibia, where its posterior border blends with the capsule of the knee joint, while its deeper layer originates with the superficial layer and it insert into the medial meniscus just above the knee joint line, which act to stabilize the fibrocartilage. Medial epicondyle of the femur is about 10 cm below the joint line. It resists valgus stresses across the knee joint, which provide secondary rotational stability. Lateral collateral ligament is a smaller and shorter ligament. It arising from the lateral femoral condyle and inserting into the posterior aspect of the fibular head. Due to posterior position, lateral collateral ligament is taut when knee is in extension. In combination with the posterior lateral capsule, it is primary restraint to various knee stresses. Anterior cruciate ligament. Anterior cruciate ligament has two bundles: anterior medial bundle and posterior lateral bundle. Anterior medial bundle is taut in knee flexion, while the posterior lateral bundle is taut in knee extension. It resists excessive anterior translation and internal rotation of the tibia relative to the femur. Posterior cruciate ligament originates from the lateral surface of the medial femoral condyle and insert on the posterior tibia approximately 1 cm distal to the articular surface. Its two bundle, anterior lateral and posterior medial bundle. Posterior bundle is taut when the knee is in extension, and anterior bundle is taut when the knee is in flexion. primary function is to prevent excessive posterior translation of the tibia. Posterior lateral corner provide restraint to various types of pathological knee motion, which include posterior tibial translation, near full extension, external rotation of the tibia on the femur, and varus rotation. It has 3 layers. First layer shown in the picture, which is iliotibial tract, bicep tendon, lateral collateral ligament, popliteus, and the second layer is lateral collateral ligament, and the third include joint capsule. Menisci. Menisci are interposed between the articular surfaces of the femur and tibia that deepens the and stabilize the tibiofemoral articulation and distribute the weight-bearing load across a greater articular surface area. It is the crescent disk of fibrocartilage. Outer third contains circumferential collagen fiber that absorbs Hope stresses. If menisci are removed, then stress may reach up to 3 times, which increase degenerative conditions like osteoarthritis. Lateral meniscus. Biomechanical studies show that the lateral meniscus transmit and dissipate approximately 70% of the compressive load in the lateral compartment, while the medial meniscus and medial tibiofemoral articular cartilage share forces across the medial compartment equally. Lateral meniscus is nearly circular and it has looser peripheral attachments. A hiatus in the posterior lateral capsule where the popliteus tendon enters the joint contains no attachment to the lateral meniscus. Greater motion on the lateral meniscus allowed by the looser capsule and bony attachment, which enables the lateral meniscus to translate during physiological knee rollback and screw home rotations. Medial meniscus is semicircular and its posterior and interior horns are attached to the tibia intercondyle eminence. The periphery of the medial meniscus is closely attached to the medial capsule and deep MCL by coronary ligaments. In picture shows lateral meniscus, its medial meniscus, red zone and white zone. Red zone vascularized through capsular attachment arising from the medial and lateral geniculate vessels, while the white zone is avascular, which is the central third part of the menisci. It provides minimal healing, while both red and white zone provided limited healing time for recovery. As shown in this picture, bursas. There are 4 bursas present in the knee joint. These bursas are distributed around the knee where soft tissues move against bony prominences or in the fascial plane. Anteriorly, prepatellar bursa is located in the sublayer between the lower half of the patella and the skin, while the deeper infrapatellar bursa lies between patellar tendon and tibial tubercle. On medial side, the anserine bursa is superficial to the MCL and separate it from the tendon of the pes acerinus, which includes sartorius, gracilis, and semitendinosus muscles. Accessory bursas may be present either medially or laterally in fascial layers separating ligaments, tendons, and bones. These are the bursas. When distended, the gastrocnemius and semimembranous bursa, which communicate with the knee joint in 50% of the adult, causes the Baker's cyst. An understanding of the location of the knee bursa and careful palpation to assess the tissue depth of the fluid collection is essential prior to attempt aspiration around the knee joint. What is the patellofemoral joint? It is the articulation between the patella and the femur. It allows movement at knee joint and the muscles. It provides gliding movements about 7 cm in vertical direction, which includes superior glide, inferior glide, and lateral and medial shifting. Muscles. Muscles provide movement and stability to the knee joint, which include quadriceps. Quadriceps are the primary extensors of the leg. Fibrous expansion from the vastus medialis and lateralis insert obliquely into the sides of the patella and form the medial and alter patellar reticula. Distal fibers of the vastus medialis obliquus insert on the medial border of the patella and are key active restraint to excessive lateral patellar subluxation. Hamstring muscles. Hamstrings are the flexors muscles of the knee joint. In medially, they provide semimembranosus and semitendinosus, or laterally, it gives bicep femoris muscle. Accessory roles include providing rotational stability and restraining anterior tibial translation relative to the femur when the knee is flexed. Iliotibial band. Iliotibial band, thickening of the fascia lata on the alter aspect of the thigh. Proximally, the IT band is in continuity with the tensor fascia lata muscle. Distally, it inserts into the lateral femoral epicondyle. With the knee fully extended, IT bands lie anterior to the axis of rotation and act as a knee extensor. When the knee flexes, the IT band translates posteriorly behind the center of rotation of the knee and act as a flexor. Pes anserinus is common tendinous insertion of the sartorius, gracilis, and semitendinosus muscle into the proximal medial tibia. Patellar tendon provides the etiology of the knee pain. Tibiofemoral motion. Biomechanical weight-bearing axis of the lower extremities follow a line extended from the center of the femoral head to the midpoint of the talus. Thus, knee at the midpoint function to transfer and dissipate loads among the femur, tibia, and patella. At knee, the mechanical axis usually crosses slightly medial to anatomical midline. It is a hinge joint, that's why it provides flexion and extension movement, which arc from 0 to 135 degree. It allows secondary movement, rollback, and rotation movement. Rollback is sliding and rotation of the femur on the tibia. As the knee flexes, the lateral femoral condyle translates posteriorly by rolling or sliding twice as far as the medial condyle. Patellofemoral motion. As knee flexes past 30 degrees, the articular surface of the patella engages the trochlear groove of the distal femur. Stability of the patellofemoral movement is called tracking, which results of the congruent osseous anatomy of the patella and trochlea augmented by soft tissues constraint. It included vastus lateralis and retroreticulum that pull the patella laterally, and the vastus medialis obliquus and medial patellofemoral ligament that stabilize the patella medially. It also has Q angle, which measures off the balance of medial and lateral forces on the patella. Q angle. Q angle is the angle between the line from anterior spheric iliac sign to the center of the patella and another line from tibia to buccal. Its normal value in man is about 13 degree and in women about 18 degree. Its abnormal value is greater than 20 degree. High Q angle reflects a large unbalanced four vectors tending to pull the patella laterally. If forceful contraction occurs, quads can cause the patella to subluxate laterally, which predisposes to patellar subluxation. It shows Q angle. Loads on the knee joint. Because the knee is positioned between the body's two longest bony levers, the femur and the tibia, the potential for torque development at the joint is large. The tibiofemoral joint is loaded in both comparison, which include compression and shear forces during daily activities. Tibiofemoral joint forces. Compression loading more in stance phase, while during shear loading, femur has tendency to displace anteriorly on tibia plateau. Stress at the joint is maximum during 180 degree to 120 degree of flexion, or minimal stress present at approximately 30 degrees of the flexion. Measurement of articular cartilage deformation on the tibia plateau during the weight bearing. Knee flexion angle exceeding the 90 degree result in larger shear forces. Full squats are not recommended for novice athletes because it provides greater stress on the knee joint and lead toward the knee injuries. The menisci act to distribute loads at the tibiofemoral joint over a broader area, thus reducing the magnitude of the joint stress and also directly assist with force absorption at the knee joint, bearing as much as an estimated 40% of the total load. Other general risk factors for development of the knee osteoarthritis include a high body mass index and meniscal damage. Forces at patellofemoral joint. Compressive forces have been found to be 1/2 of the body weight during normal walking gait, increasing up to over 30 times body weight during stair climbing, which increase compressive forces during knee flexion. So squatting highly stressful to the knee complex. There are two reasons for this. First, the increase in knee flexion increases the compressive component of the force which acting on the joint. Second, as flexion increases, a large amount of quadricep tension is required to prevent the knee from buckling against the gravity. So the squat has been shown to be an effective exercise for use during rehabilitation following cruciate ligament or patellofemoral surgery. Training within the 0 to 50 degree knee flexion range is recommended for those who wish to minimize knee forces. Thank you.